This is Wilkins Chapter 15, Dental Biofilm and Other Soft Deposits. During the clinical examination of the teeth and the surrounding soft tissues, soft and hard deposits are assessed. And the presence of dental biofilm, as you know, is the primary risk factor for gingivitis, inflammatory periodontal disease, as well as dental caries. So assessment is the integral aspect of the dental hygiene diagnosis, and on the basis of assessment findings, an individual preventive care plan is formulated to meet the needs of that particular patient. So review the key words on box 15.1. And soft deposits include acquired pellicle, dental biofilm, Materia Alba, as well as food debris, and we're going to be talking about each one of those. And the hard calcified deposits on the teeth are the dental calculus, which we have another whole chapter on. And the comparison of different types of deposits with their descriptions is also found on table 15.1, so review those. So the acquired pellicle is a thin, acellular, tenacious film formed of proteins, carbohydrates, as well as lipids. Every board exam seems to have a definition of what the acquired pellicle is. And the pellicle is uniquely positioned as the interface between the tooth surface and the oral environment. It forms over exposed tooth surfaces as well as prosthesis. Pellicle thickness varies from 100 to 1,000 nanometers depending on the location in the mouth. It is thickest near the gingival margin and areas of undisturbed by the activities of chewing, swallowing, and speaking. So it's thickest near the gingival margin and areas of undisturbed activity. So the formation of the pellicle forms within minutes after eruption or after all soft and hard deposits have been removed from the tooth surface. So when you have your teeth polished, for example, with the gritty prophy paste, that removes the acquired pellicle. And the pellicle begins to form and is fully formed within 30 to 90 minutes. The composition is primarily glycoproteins that are selectively adsorbed by the hydroxyapatite of the tooth surface. And the protein components are derived from the saliva, oral mucosal cells, the gingival crevicular fluid, as well as other microorganisms. So the initial attachment of bacteria to the pellicle is by selective adherence of microorganisms that originate from the oral mucosa. There are innate characteristics of the pellicle that determine the adhesion interactions that cause planktonite bacteria to aggregate or form clusters to initiate biofilm formation. So we have salivary proteins that have a high affinity for the hydroxyapatite tooth surface that actually initiate the process of pellicle formation. The adsorption material becomes a highly insoluble coating over the teeth, existing calculus, restorations, as well as partially or complete dentures as well. There are different types of pellicle. You have supragingival pellicle, and that supragingival pellicle is clear, translucent, it's insoluble, and not readily visible until there's a disclosing agent that's been applied. Pellicle can take on extrinsic stain and become gradations of brown, gray, also orangey yellow, or other colors. And we have a whole chapter on chapter 22 is on stains. But when stained with a disclosing agent, the pellicle appears thin and with a pale staining that contrasts with the thicker, darker staining of dental biofilm. So the pellicle is going to be translucent and clear, even though it might pick up some stain, but the dental biofilm is quite different. You also have subgingival pellicle, and subgingival pellicle is continuous with the supragingival pellicle and can become embedded in the tooth structure, particularly where the tooth surface is partially demineralized or rough, be it from iatrogenic dentistry or a decalcified area. The pellicle plays an important role in the maintenance of oral health because it protects, it lubricates, and it acts as a nidus or an attraction for attachment of bacteria as well as subsequent calculus on the tooth surfaces. But the pellicle also has a protective side to it, and it appears to provide a barrier against acids impacting remineralization as well as demineralization. The pellicle acts as a lubricant because it keeps the surfaces moist and prevents drying, which can in turn enhance the efficiency of speech as well as chewing and mastication. And it is a nidus for bacteria because the pellicle participates in biofilm formation by actually aiding in the adherence of microorganisms. The pellicle can also be a means of attachment of calculus, and one mode of calculus attachment is to the pellicle, and we will get into that in Chapter 21. So the pellicle is not resilient enough to withstand rigorous patient oral self-care, and extrinsic factors that may interfere with pellicle formation as well as pellicle maturation include abrasive toothpaste, especially the whitening toothpaste, anything that has grit to it. Whitening products with the hydrogen peroxide inhibits pellicle formation, and the intake of acidic foods as well as acidic beverages can also inhibit pellicle formation. So let's go into talk a little bit about dental biofilm. This is what we are all about. It is the primary etiological factor for most things that go wrong in our mouth. The dental biofilm is a dynamic, structured community of microorganisms that are encapsulated in a self-produced extracellular polymeric substance, EPS, extracellular polymeric substance, that form a matrix around microcolonies. And the matrix is composed of polysaccharides, proteins, and other compounds. It acts to protect the biofilm from the host's immune system and from antimicrobial and antibiotic agents as well. So the microcolonies are separated by a network of open water channels that supply nutrients deep within the biofilm community. This is a living organism. And a three-dimensional structure of biofilms enhances their ability to communicate with each other, adapt to their environment, and respond to their environment. Dental biofilm adheres tenaciously to any inert or living moist surface. In the oral cavity, biofilms initially adhere to the pellicle on teeth, existing calculus, fixed as well as removable restorations. And biofilm communities also form on the oral mucosa, surfaces of the tongue, the tonsils, and their presence is especially on the tongue and tonsils that may contribute to halitosis or malodor. There are now over 700 distinct bacterial species found in the oral cavity, along with a variety of other microorganisms, including viruses, protozoa, and yeast. The morphological forms of bacteria that are found within the biofilm are shown in Figure 15.1 of your textbook. But you need to know what the stages in the formation of biofilm is. So biofilm formation does not occur randomly, but it involves a series of complex interactions that are predictable and specific to oral biofilm development. Gene expression controls many of the growth and attachment capabilities and varies depending on the species or variety within the biofilm community. So with 700 distinct bacterial species, every mouth is going to have a different composition of that 700. So stage 1 is the formation. And biofilm formation begins with the initial attachment of planktonite bacterial cells to the pellicle on the tooth surface by way of the bacteria's interaction with the pellicle. It's called physiochemical interaction. Initially, the adherent cells are not yet committed, so to speak, to this process, and during this stage of adhesion, the process is reversible. When the cells are disrupted, that would occur with, say, brushing or flossing, they can dislodge from the surface and resume planktonite-type life, either be eliminated or begin the formation process elsewhere in the oral cavity. So that was stage 1. Stage 2 is bacterial multiplication and colonization. If the planktonite or the planktonic microorganisms are not removed, they will attach themselves more permanently using cell adhesion structures such as fimbriae, pili, flagellae, those type of things, as well as adhesion proteins. Microcolonies multiply in layers, growing upward and outward, creating a three-dimensional aspect of biofilm structures. With increased size, colonies produce extracellular polymeric substances, the EPS, to firmly attach to an irreversible manner. Rough surfaces will result in a more rapid, irreversible attachment. It makes sense, doesn't it? Organisms that colonize within the first few hours are primarily gram-positive, cocci or cocci, depending on how you say it, and rods. Gram-positive, cocci, and rods. Then you've got stage 3, which is the matrix formation. And bacteria within the aggregate of cells continue to secrete the EPS as bacteria multiply to form a matrix. The components of the EPS are your polysaccharides, your glucans, your fructans, or levans produced by certain bacteria within the community and from dietary sucrose as well. The polysaccharides are sticky and cement the biofilm more firmly to the teeth. The EPS matrix anchors the bacteria together, and that increases its adherence to the tooth and other structures. And in that way, the bacterial community is protected and continues to grow. The adhesion and stickiness of the EPS matrix make biofilm disruption more challenging. And ineffective toothbrushing is not going to adequately disrupt the biofilm. The biofilm structure enhances its ability to survive, thrive, and adapt to the ever-changing environments within the oral cavity, both supragingivally as well as subgingivally. The adaptive characteristics, structure, and the EPS of the biofilm limit the ability of antibiotic therapy to reduce the virulence of the pathogenic bacteria found deep within the biofilm community. So antimicrobials, especially antibiotics, are not that effective against the damaging effects of the dental biofilm. Then, stage 4, you've got biofilm growth. This stage is characterized by further development of the biofilm architecture that enhances the cell-to-cell communication process. It's activated by specific genes located on the surface of the bacterial cells within the biofilm itself. The mass and thickness of the biofilm increases as a result of bacterial multiplication, and if left undisturbed, bacteria continuously adhere to the biofilm community and surrounding surface area. Then stage 5, you have maturation. And bacterial colonies mature and release planktonic cells to spread and colonize other areas within the oral cavity. The bacteria can disperse as single cells or in clumps. And the changes in the biofilm microorganisms, the dental biofilm consists of really a complex mixture of microorganisms in microcolonies. And the microbial density is very high, and it increases as biofilm ages and matures. The potential of the development of dental caries and gingivitis increases with the more microorganisms, especially as the numbers of pathogenic microorganisms outnumber the non-pathogenic microorganisms. The pellicle, EPS, biofilm architecture, and resulting environment promote anaerobic gram-negative bacterial cell activity. Now, if you remember, when the biofilm first forms, it's aerobic gram-positive. it converts to an anaerobic gram-negative when it matures and gets older. So with undisrupted biofilm, or if the numbers of the bacteria increase rapidly, the chance of potential disease activities like dental caries, gingivitis, or eventually other inflammatory periodontal disease actually increases. The changes in the oral flora follow a pattern such as that's going to be shown in figure 15.2 of your book, and vary by days of accumulation. So, days 1 and 2, you have early biofilm that consists primarily of gram-positive cocci. You've got the streptococci, which dominate the bacterial population, include the Streptococcus mutans, the strep mutans, and Streptococcus sangrius. Then on days 2 to 4, the cocci still dominate, and increasing numbers of gram-positive filamentous form, as well as slender rods join the surface of the cocci colonies. Gradually, the filamentous forms grow into cocci layers and replace many of the cocci. People who form biofilm slowly will exhibit more cocci and fewer filamentous forms. So everybody develops biofilm, but at a slightly different rate, and again, with 700 different distinct microorganisms, the makeup of the biofilm is going to change from person to person. So we've got days 4 to 7 now, and that's when the filamentous, or the filaments increase in numbers, and you've got a mixed flora that appears to be comprised of rods, filamentous forms, as well as fusobacteria. The biofilm near the gingival margin thickens as a more mature flora develops. Now remember, that is also where it's most likely to be undisturbed. Gram-negative spirochetes and vibrios start to proliferate. As the biofilm spreads coronally, newer and younger biofilm is, again, primarily coccal in relationship. Then we have days 7 to 14, and that's when the vibrios and spirochetes appear and the number of white blood cells increases. And remember, the white blood cells, or leukocytes, are disease-fighting cells, infection-fighting. During this period, inflammation develops and can be observed in the gingival tissue. So you're not going to see inflammation until days 7 to 14. Days 14 to 21, in older biofilm, you've got vibrios and spirochetes are prevalent, with again fewer cocci, and filamentous forms, because there's only so much space that this biofilm can encapsulate, so the types and forms of bacteria changes. The densely packed filamentous microorganisms can arrange themselves perpendicular to the tooth surface in a palisade type of arrangement. And as biofilm matures and thickens, there are more gram-negative anaerobic organisms that appear that seem to be protected by the biofilm architecture as well as the environment. So, days 14 to 21, gingivitis is clearly evident. And this is figure 15.2 of your textbook, which just is more of a pictorial of the different types of bacteria with the different stages of biofilm accumulation. And this is one of the classic pictures of biofilm that you will see in a lot of the continuing education courses and in the literature, but you can see where the attachment on the left side starts, and then it goes to cell adhesion, cell proliferation, to maturation, and then chunks break off, and the planktonite bacteria then starts the attachment all over again. But this is a very sophisticated environment. And this is another picture that you will, again, be seeing quite a bit. And you can see where things look like a jellyfish, and down below where you can see the tentacles, those are those microchannels where the water and fluid can intersperse as well as feed all the bacteria. Yet again, another picture where you've got the palisade. The left side is your tooth surface and the different bacteria. And bacteria is forever breaking off and reattaching. Remember the planktonite bacteria, the planktonite cells that get shed and get disrupted will float and adhere again, and if they are not disrupted, they will mature into different types of organisms. So you can see that there is a lot of different pictures out there that depict biofilm formation. I like this one because it happens to have the specific bacteria that is involved. We're going to be learning about this specific bacteria more so in perio, in DNH 146. But take a look at the adhesion and the receptors down at the bottom of the page. You've got your tooth surface, then the acquired pellicle on top of the tooth surface, then those triangles. And on top of those triangles, you have different bacteria. And the bacteria, you've got the good guys and the bad guys, and everybody's got bacteria in their mouth. And then you've got the receptors and adhesions that start taking place, so things can start sticking together. Those are your early colonizers, and if things are not disrupted, you have your late colonizers. And those late colonizers are your treponema, your H. pylori, which you might have heard about when it comes to ulcers, and your AA. There's something called experimental gingivitis. Sometimes the boards will ask a question on this, and these are the studies that take place to give us this evidence-based on how gingivitis actually forms. And gingivitis develops in 2 to 3 weeks when biofilm is left undisturbed. Most gingivitis, is reversible with mechanical biofilm disruption, and healthy gingiva can return within just a few days. But an experimental gingivitis program was done to demonstrate the effects of biofilm, and you can do this yourself. This was done in a dental school where dentists did not brush for a period of 21 days, and they were taking bacterial samples as well as histological signs, and that's where they came up with the stages of gingivitis. So let's get into more of the dental biofilm. The subgingival biofilm results from the apical proliferation and migration of the supragingival biofilm. So what happens on top of the gum line has a direct effect for what happens underneath the gum line. And in early stages of gingivitis and periodontitis, the supragingival biofilm is a strong influence on the accumulation as well as the pathogenic features of the subgingival biofilm. And if you look back on table 15.2, it will give you some of the characteristics of both super and subgingival biofilm. But for the microorganisms, the recent technology innovations like the confocal scanning electron microscopy, as well as other types of microscopy and DNA probes and gene amplification sequencing have allowed a more in-depth understanding of the science in biofilms, and that is a whole section of medicine. Biofilm occurs on wounds as well, and there's a lot of study on the biofilm in wound healing or the lack of healing. The supragingival flora, though, is primarily gram-positive aerobic bacteria. It utilizes air. Several species populate early what we call healthy supragingival plaque. Both Streptococcus as well as Actinomyces species are closely aligned with the Lactobacillus and Candida species, such as the flora matures. Subgingival biofilm includes more predominantly gram-negative anaerobic as well as motile organisms. So healthy bacteria in the mouth is aerobic, gram-positive, and generally non-mobile or non-motile, versus disease-causing microorganism is generally anaerobic, gram-negative, and motile. So you've got your actinomyces, your Tannerella forsythia, your fusobacterium, as well as other type of bacteroides that have been identified. And the study of biofilms has led to the identification of 6 groups of subgingival bacterial species in undisrupted aging biofilm. So you've got your early colonizers, and those are usually depicted as yellow or blue. And if you look on figure 15.3 of your textbook, you can see the different colonizers. So the yellow and blue are the early colonizers, and they transition to predominantly gram-negative microorganisms depicted by the orange and red-colored complexes. Older undisrupted biofilms consistently contain more of the orange and red species complex. Now, for the subgingival biofilm, the biofilm architecture arranges itself in layers. The initial layer is composed of actinomyces that gives rise to an intermediate layer composed of spindle-shaped cells such as fusobacterium, Tannerella, and Tannerella forsythia. The top layer is composed of bacteroides clusters and spirochetes, which form a palisade-like lining. But many gram-negative microorganisms and a number of white blood cells are loosely attached to the pocket epithelium. There's virulent pathogenic microorganisms in this layer that can be infectious. And from this layer, microorganisms may invade the underlying connective tissue. And on figure 15.4, it shows bacteria within the connective tissue and on the bone surface. Now you can imagine, once it invades the connective tissue, scaling, root planing, root debridement is not going to be able to remove the bacteria that's embedded in the soft tissue or in the bone. So what is the composition of dental biofilm? There are microorganisms, and the EPS comprise 20% of the biofilm that are organic and inorganic solids. The other 80% is water. The composition differs among individuals and among tooth surfaces. Inorganic elements, you've got calcium and phosphorus, as well as magnesium. Saliva transports the minerals during the mineralization and demineralization process. There's also fluoride that is found in biofilm, and the concentration of fluoride in biofilm is higher in the presence of fluoridated water and increases following a professional topical application of fluoride and the use of fluoride-containing toothpaste and mouth rinses. The organic EPS surrounds the microorganisms of biofilm and contains primarily carbohydrates and proteins with a small amount of lipids. And carbohydrates include glucans such as dextran and fructans or levans formed by bacterial metabolism of the dietary sucrose. Carbohydrates contribute to the adhesion of microorganisms to each other and to the tooth, adding to the biofilm's stickiness and tenacity for the adherence to tooth surface. Then there are also proteins of supragingival biofilm that originate from the gingival sulcus or the crevicular fluids. For the distribution of biofilm, supragingival biofilm, of course, is coronal to the gingival margin. Gingival biofilm forms on the external surface of the oral epithelium and attached gingiva, whereas subgingival biofilm is located between the epithelial attachment and the gingival margin within the sulcus or the pocket. There's also fissure biofilm, and that develops in the pits and fissures of the teeth. And interestingly, each of these biofilms has a different type of community and composition of bacteria. So the biofilm by distribution is going to be location, by surface. During formation, supragingival Biofilm formation begins at the gingival margin, particularly on the proximal surfaces, and extends coronally when left undisturbed. It spreads over the gingival third and towards the middle third of the crown. The tooth surfaces involved. Biofilm is the heaviest on proximal surfaces and around the gingival third associated with protected areas. So the palatal surfaces of the maxillary teeth may have the least biofilm because of the activity of the tongue and chewing and speaking. That area of biofilm tends to get disrupted more easily. Factors influencing biofilm accumulation: crowded teeth, rough surfaces, occlusion. Deposits can extend over the entire crown of an unopposed tooth. And the removal of biofilm, manual or power brushing, is the most universal daily mechanical disruption method that we have. Dental flossing and other proximal surfaces of biofilm disruption are necessary as well. So how do we detect biofilm? For thin biofilm, it can be translucent and not really visible without a disclosing solution. Then there's stained biofilm. Extrinsic stains may make biofilms more visible: yellow, green, tobacco stains, for example. The thickness of the biofilm: the tooth may appear dull, dingy, with matted or actually fur-like surface. Materia alba or food debris can also collect over biofilm. So you can use an explorer or a probe and use a tactile examination, but when calcification has started, the biofilm can feel slightly rough, and the surface may feel slippery from the coating of the soft, slimy biofilm. For removal of biofilm, biofilm may be detected by passing the side of the tip of the probe over the suspected tooth surface, and when present, the biofilm adheres to the probe. But we oftentimes will use on all of our patients a disclosing agent. And when a disclosing agent is applied, the biofilm takes on a color and becomes readily visible. So disclosing agents are applied only after the evaluation of the oral mucosa and the gingival color has been reported. So the periodontal examination and oral inspection, the cancer screening, have been done already. A specifically designed form with several charts of the completed dentition on paper charts allow for space to do a biofilm or plaque index. We do that on the computer. A lot of students will do it on paper first and then put it in the computer. And you record biofilm by location and also by thickness. Is it slight, moderate, heavy? For objective evaluations, an index of biofilm score is used, and there's a whole chapter on indexes, but we are going to be coming up with a plaque index, a percentage of, and it's a percent how many tooth surfaces have biofilm on it, and we incorporate that into our oral health education with our patients. Biofilm scores are then able to be compared over time and used to develop a biofilm control plan with our patients. Biofilm scores are also a component of the permanent patient record. And this is just, it's a blurry picture, I apologize, but when you disclose somebody, this is not uncommon as far as what you would be seeing. And as you know, the gingival margin is a more likely area for the biofilm to collect first. It's a difficult area to brush adequately, so a lot of times this is an unprotected area. So you would be counting up all of those surfaces and coming up with a percentage, as well as a description of the thickness, location, and the age. We have two-tone disclosing solution. So the light pink is biofilm that is relatively new, 24 hours or so, and the darker the purple and the thicker, the older it is. So if somebody brushed in the morning and they're seeing you at 4 o'clock in the afternoon, you can expect to see some biofilm accumulation. But if it was dark purple or really dark pink and thick, you know that that's someplace that they did not brush that morning, and it's an area that you need to concentrate on. So microbial biofilm plays a major role in the initiation and progression of both dental caries and periodontal disease. As you know, that's always the primary etiological factor. Periodontal disease and dental caries are considered infectious, transmissible diseases caused by pathogenic microorganisms found in oral biofilm. So biofilm is significant in the formation of dental calculus, which is essentially mineralized dental biofilm. Optimal oral hygiene depends on consistent daily dental biofilm disruption, as complete removal of all biofilm is really impossible, but we want to be disrupting as much as possible. Accumulation of dental biofilm on teeth, tongue, tonsils, and oral mucosa contributes to a lot of the patient's malodor and unpleasant personal appearance. And this one's from your book, figure 15.5, of what tooth positioning might be involved with. You can see with the crowding that there are some protected areas where the toothbrush is having a real hard time reaching. So on the facial surface, the anterior on the top where the arrow is, the toothbrush can reach fairly readily, but on the lingual surface, the toothbrush can't because it is a more protected area. And this is what it can look like when you're not using any disclosing solution, but you can see that it's very rough, it's fur-like, and it actually feels rough, or like a carpet, we sometimes say to the patient, because they can feel the difference when it's on their teeth and then when it's removed. Dental caries is a disease of the dental calcified structures that's the enamel, dentin, and cementum, characterized by demineralization of the mineral component and dissolution of the organic matrix. Clinical characteristics and types of cavitated dental caries is going to be discussed in Chapter 16, and the process of dental caries is also described in Chapter 27, so you are going to be learning more about that. The sequence of events leading to demineralization and dental caries is shown on figure 15.6, and I've got that coming up in a couple of slides here. Let's see. There. So we've got our cariogenic microorganisms. Okay, so we're starting at the top here of the picture. You've got your strep mutans, the streptobrinus predominantly, as well as your lactobacillus that initiate the etiological agent. The streptococci initiate the caries process, and lactobacilli contributes to the progression of the carious lesion. So you've got to have the strep mutans start it and the lactobacilli take over. Xerostomia, or decreased salivary flow, as well as frequent fermentable carbohydrate exposure, promote the growth of the strep mutans and lactobacilli in the dental biofilm. So it's not so much that they're saying the amount of sugar or fermentable carbohydrate, it's the frequency of exposure that puts the patient more at risk. Biofilm architecture, as well as the EPS matrix of the biofilm community, helps maintain the caries-causing acetic environment. So the pH of biofilm, acid formation begins immediately when the cariogenic substance is taken into the biofilm. So let's say you take a swig of Mountain Dew or of Coke. The pH of the biofilm is lowered quickly, and 1 to 2 hours are required for the pH to return to a normal level, assuming the biofilm is left undisrupted. So biofilm pH before eating ranges 6.2 to 7, okay? And that's it's lower in the caries-susceptible person and higher in the caries-resistant person. We've all seen in dental practices somebody who is eating M&Ms all day and never seems to have any cavities, versus their sister or brother is brushing 3 times a day and never eats sweets and always seems to have breakdown. That person's innate pH also has a factor in it. But immediately following sucrose intake into the biofilm, there's a rapid drop of pH. And the critical pH for enamel demineralization, and this is key here, you have to know this, is 4.5 to 5.5. Enamel, critical pH, 4.5 to 5.5. The critical pH for root surface demineralization is 6 to 6.7. Especially relevant for patients with multiple areas of recession as well as xerostomia. So 6.7 is almost neutral, so the pH really doesn't have to lower all that much for the susceptible patient to get into trouble. And the amount of demineralization depends on the length of time as well as the frequency the pH is below that critical level. So biofilm density and maturity are additional factors that also affect the caries process. So each meal or snack that contains sucrose, the pH of the biofilm is lowered. And the quantity of sucrose or carbohydrates eaten is less damaging than the frequency sucrose is eaten with meals, and less damaging than as snacks. So the frequency is now how many times are you eating something and for how long. So now it's not so much as you're eating the bag of M&Ms. We're recommending if you're going to eat the bag of M&Ms, eat it with a meal and eat the whole bag. Don't be taking 2 or 3 M&Ms every half hour and chewing them, because that pH will then always be at that acidic level. There are cariogenic foods. With a high cariogenic diet, biofilm forms and grows more profusely when oral hygiene is neglected or inadequately performed. So patients fed sucrose by the stomach tube have less acetogenic biofilm than those fed sucrose by mouth, because the oral microbe is avoided altogether. The Materia Alba is a loosely adherent mass of bacteria and cellular debris that frequently occurs over the surface of undisturbed dental biofilm. The appearance, Materia Alba really means white material, and is distinguished as a bulky, soft deposit that is clinically visible without the application of a disclosing solution or a disclosing agent. It is white or a grayish white, sometimes with a cottage cheese type texture and appearance. Materia Alba is an unorganized accumulation of living and dead bacteria, desquamated epithelial cells, disintegrating leukocytes, salivary proteins, and possibly a few particles of food debris. And that differs from the organized oral biofilm, because oral biofilm is a very organized living entity of microcolonies, versus Materia Alba is just a dumping ground. Surface bacteria in contact with the gingiva contribute to gingival inflammation. The tooth surface demineralization and early non-cavitated lesions can also be seen under Materia Alba, so we have to be very careful when we are removing Materia Alba, because we don't know the condition of the tooth that we're going to find. But Materia Alba can be removed oftentimes with a water spray, an oral irrigator, or with the tongue action. The tongue can dislodge it, whereas only the surface microorganisms of biofilm can be removed. Clinical distinction of Materia Alba, food debris, and dental biofilm is really necessary, but the patient instruction for the removal of all of them remains the same as all biofilm removal. For food debris, we have loose food particles that can collect around the cervical third and proximal embrasures of teeth. Cariogenic foods contribute to dental caries because liquefied carbohydrates diffuse rapidly into the biofilm, and so they make more acid-forming bacteria. For food impaction, when there are open contacts, mobility of teeth, or irregularities in occlusion, such as plunger cuts, food can be forced between the teeth during chewing, and this could result in vertical food impaction. There's also horizontal or lateral food impaction that occurs on the facial and lingual embrasures, particularly when the interdental papilla are reduced or missing. Think about after you eat popcorn or spinach or broccoli, and you do that quick check of your front teeth. That's the horizontal or lateral food impaction. Versus the celery that is stuck between two teeth, that is the vertical food impaction. So food debris adds to the general unsanitary condition of the mouth, and some self-cleansing through the action of the tongue, lips, saliva, and swishing can take place. But debris removal by toothbrush and interproximal biofilm removal techniques really constitute a total biofilm control program. And cleansing of food debris from around 6 prosthetics, orthodontic appliances is necessary to help prevent disease. So like everything, we always end with documentation, don't we? The permanent records for each patient is going to include information on the soft deposits, including the clinical description of the appearance of the teeth relative to biofilm, Materia Alba, and food debris as indications of their personal oral care on a daily basis. There's usually notes on the patient's understanding of biofilm and the significance of various deposits, and the patient's description of the methods used, what they're doing for their self-cleansing, as well as what you have recommended and demonstrated for them on how to better control things. So this is really the crux of our oral health education with our patients, because it all does start with the biofilm. So the more we can increase our patients' knowledge on what's going on in the mouth, the more they may be able to buy into the cause and prevention of dental decay, as well as periodontal disease, and the effects of personal oral care procedures that they can do to help control things in their mouth. So that is it for dental biofilm.